kicking things off, we have a really, really great guy who's beginning the conference for us, Dr. Haney Mallemat. Haney is triple trained in emergency medicine, internal medicine, and critical care. He did his emergency medicine, internal medicine training in New York, and then his critical care fellowship at Dartmouth. And during his fellowship, he also became trained in critical care ultrasound and echo. So he's one of the very few emergency physicians in the country, maybe even in the world, who has special training in echo and certification in echo. He's over the years become an expert in all of these four areas: EM, IM, critical care, and echo. He's a master clinician, and also, as you'll discover, he's truly a master teacher. He runs his own resuscitation conferences and also provides some teaching and conferences on how to give medical presentations. So with that, I'm going to hand things over to Haney. He's going to be spending some time talking about the use of ultrasound in the peri-arrest period. So again, thanks for joining us. And Haney, please take it away.
Thank you, Amal, and good morning to all of you around the world, or maybe good evening. What I want to talk to you about today is something I am extremely passionate about, and that's ultrasound in cardiac arrest. And I want to tell you a story about what illustrates why this is so important. I trained in emergency medicine and internal medicine, as Amal said. Then when I went to go do my fellowship up in New Hampshire, I was pretty certain that ultrasound would be a vital component, as it had been during my training, of all resuscitations. One of my first nights on call, there was a code that was called overhead. Now, the expectation was not that fellows were to go to the codes, but I felt I'm a critical care fellow. That patient will likely be coming to me. What better chance to get to know the patient than go to the code? So I went to this code, and by the time I got there, it was your typical code on a floor. Chaos in the room, 20 people running around, screams everywhere. At the head of the bed was the medical resident with the ACLS card calling things out. Came into the room, I introduced myself and said, how long have we been to this code? And they said 20 minutes. I said, great. And so I stood by the medical resident, and the medical resident just said to me, you run the code. And I said, okay, sure, I'll run the code. Where's the ultrasound machine? And everyone kind of just looked at me and was like, ultrasound machine? I said, we need an ultrasound machine if we're going to run this code effectively. And so I told the tech to go to the ICU and bring back our ultrasound machine. And so as we started to do this code with me in charge, I actually kind of felt like the medical resident at the head of the bed. I didn't have any data. I just kind of reviewed the facts and ran through the protocol. And 15 minutes went by, the ultrasound machine wasn't there. And then another 10 minutes later, so now we're 45 minutes to the code, the ultrasound machine rushes into the room. And during the next rhythm check, I put the probe on the chest. We found pericardial tamponade with standstill. I'm pretty certain this person is already dead and there's nothing to do here. But we did a pericardiocentesis, got fluid, ran the code for another 20 minutes. And ultimately, we did not get return of spontaneous circulation. And that set the tone for what I wanted to do in emergency medicine and critical care. I wanted to bring ultrasound to every code. And what I want to do today is tell you why ultrasound is so vital to every single code that we do. It's 2023, and it's time we start updating our level of care for our sickest patients in the hospital. So again, my name is Haney Mallemat. I work at the Cooper Medical School at Rowan University down in Camden, New Jersey, right outside Philadelphia, where I do emergency medicine, I do critical care, and I teach ultrasound and echo. Now, I have no financial disclosures to make, but as Amal said, I run a course and a conference called ResusX. We have lots of free resources up there. Please go ahead and check it out after the conference is done. It focuses on people who are your sickest patients, and it's really my passion to help people learn resuscitation the proper way. So let me give you the landscape of what we're going to be doing today. We're going to cover 4 areas. We're going to talk a little bit about the history of cardiac arrest and show how we're probably no different than we were back 100 years ago or 500 years ago during cardiac arrest. We'll talk a little bit about the meat of what ultrasound is about, the reversible causes, the prognosis, and how it can help you with your procedures. We'll spend a little bit of time talking about the pitfalls of ultrasound because it can't all be perfect, but I'm going to give you some strategies for how you can incorporate ultrasound into your code and save more lives. And then finally, I hope to talk about the future of ultrasound in cardiac arrest and what that means. So let's get into it and let's talk about the history. And this illustration that you see right here is a Swiss physician called Paracelsus, who the 1500s, 1530 or so, was the first documented form of resuscitation by putting a bellows device and ventilating the patient manually. Now, I wanted to keep this conference clean. I did not show the tobacco enema picture that most people show, but just realized that there was some pretty crazy things happening when it comes to resuscitation back a few hundred years ago. In the 1856 time, there was Hall, who was a London physician, who realized that maybe rolling patients on their sides and applying gentle thoracic pressure would help with resuscitation. Also in London around that time was Sylvester, who said maybe if we put our arms up and down and gently compress on the chest, that would be a form of resuscitation. But it wasn't until 1850s that we had Peter Safar, who's actually not that far away from the University of Maryland, where he was at the, I believe it was called the Baltimore Hospital at that time, created what we know today as modern day CPR, ventilating your patients, pushing on the chest, doing defibrillations. And although we don't do mouth-to-mouth CPR anymore for our patients, not much about this paradigm has changed in over 60 years. We're pretty much doing things exactly the same. And unfortunately, one of the things that we do the same is we're still using our digitometers. This is not my term. This is Joe Belezzo's term, and I love it. If you think about it, for all the things that we do for our patients, for all the resuscitation, for all the people power we put into a code, we check our work with fingers. And it's a shame in our age of technology that that's the best that we can do. And it's not just my hatred of the fingers. It's just that they're just not sensitive. Now, this is an older study where they took about 200 paramedics. They took them up to the OR and they put the patients on cardiopulmonary bypass. The paramedics were blinded whether or not they were on cardiopulmonary bypass. When you're on bypass, you have no pulse because you're on a heart-lung machine. But what they asked the paramedics is if they felt a pulse. Now, only 17% of those paramedics got things right, meaning under 10 seconds, they were able to accurately assess whether or not there was a pulse or there was not a pulse. Here's where it gets interesting, though. For most people, even the ones that got it wrong, it took 24 seconds for them to make a decision, well beyond the 10 seconds that we allot patients during our rhythm check. There were people that said they felt a pulse when in fact there was no pulse. And there were people that said there was no pulse when in fact there was a pulse. So your digitometer is grossly inaccurate. And you might say, well, those are paramedics, but paramedics are the people who have boots on the ground and who do this more often than we do on a day-to-day basis. So I would consider them to be the experts. And based on my own clinical experience, I can tell you this is probably pretty accurate from what I've seen when people say there's no pulse. We use ultrasound to confirm later on, but we'll get into that a little bit later. Your fingers are also inaccurate for situations like this, where you see a QRS complex and you don't feel a pulse. Well, you have two decisions to make over here. Is it what we know as true PEA, which is the ultrasound on the left, and you can clearly see there's no cardiac contraction happening here. So is that true PEA, or is it the one that's right before that, the one on the right, which is pseudo PEA, where you have cardiac activity, but either the person's not accurately feeling the pulse, or the systolic pressure is so low that ventricles working so weakly that's not able to generate a pulse. This is severe cardiogenic shock. Perhaps this person doesn't need chest compressions. Perhaps they need inotropes or even mechanical CPR. Again, more on that later. But your fingers can't tell the difference between the two, and both of these patients would be treated very differently. Now, people who love what we do with cardiac arrest, who don't like ultrasound, will say, well, don't worry about it. We have the H's and the T's and they will save us. But I think we all can agree that the H's and T's cannot help you when you have resuscitation. If we sit here right now, all relaxed with your coffee in hand, yeah, sure, you'll be able to get most of these H's and T's, if not all. But that's not where we operate. With 20 people in the room, everyone screaming in a chaotic situation, you're going to have to do a thorough history, get collateral from family, do a physical exam on your patients. Are you going to be able to do that? This is usually how I look during most codes. So we have to take away the chaos, take away the confusion, and use an objective tool that will help us to figure what else is going on with our patients. So I got to say, in 2023, when we have self-driving cars, mRNA vaccines and robotic surgeries and all the amazing technological skills, I don't think we're much better than Paracelsus with just sticking a bellows and ventilating our patient. But there's hope. And we'll talk a little bit more now about the use of ultrasound in a code. Now, one of the best benefits of ultrasound is that we can identify reversible causes for our patients. That's the magic about using ultrasound in a code. You can identify the cause of the code, and then you can go ahead and procedurally reverse it. And we'll get into some examples as we go through here. Now, when we talk about the H's and T's, let's face it, acidosis, hypoxemia, hypothermia, those are all theoretical constructs that we work through, and those are fine. The things that we really need to reverse immediately and treat are these things right here. We need to know if the patient's hypovolemic. We need to know if the person has pericardial tamponade, if they're having a massive MI and there's pump failure. Are they having a massive PE, or is there tension pneumothorax? Those are the things that I want to identify, because I can fix those things rapidly while I'm resuscitating the patient and hopefully get return of spontaneous circulation. And none of these things, absolutely none of them, can be determined with my digitometer. So let's start off with hypovolemia. And these are going to be examples of ultrasounds. Now, if you don't know ultrasound, it's okay. I'm going to walk you through this, but I want you to start to understand just how easy some of these things are. So this person got return of spontaneous circulation during one round of CPR, and this is an apical 4-chamber view. And you see both ventricles here are very hyperdynamic. They're almost collapsing. This tells us that the person's hypovolemic. And now we have to figure out why. The next ultrasound was put on their chest. We found that there was a huge hemothorax. Later, we found out that the person was super therapeutic on their RNR, but it didn't matter in that moment. We massively transfused them with blood. We resuscitated them, and that person left the hospital. We would have never found this had we just been using our fingers alone. Another patient came in who got ROSC, and we found this. And this is a picture of their aorta. But see, that's not their aorta right there. That's just the open lumen. This is the width of their aorta, 8 centimeters big, with a retroperitoneal leak. After ROSC and resuscitation, this person went to the OR. And again, how good are our fingers about detecting this? We're going to talk a little bit about pericardial tamponade. Now, interestingly, the ultrasound in cardiac arrest literature is not vast, but it is growing. And there's one study that I'll reference for you later that looked at patients who had pericardial tamponade, and if found with ultrasound and drained, 1 in 6 or 15% of those people left the hospital. They survived the hospital discharge. That's pretty big if you find it. And I want to know whether or not the person has tamponade right when I'm resuscitating the patient, not at the very end of the code and say, hey, should we stick a needle in the chest and see what happens? Now, let me just say also, forgot to mention it, all the references and a handout with some key points are going to be given to you at the end of this talk. So if you're scribbling down notes or wondering where the references are, just relax. I got everything for you at the end of the talk. But right there, big pericardial effusion, and this is why they weren't able to palpate a pulse on this person. The pericardial effusion was drained, and the patient survived. Here's a person with a massive MI. Look at this LV barely contracting. This LV is not able to generate a palpable pulse, and that's why this person is arresting. I want to know this as an intensivist or an emergency medicine doctor, because does this patient need to go to the cath lab? Do they need an intra-aortic balloon pump? Do they need ECPR or VA ECMO to help support this person's circulation? All these things can be told by using ultrasound at the bedside. This is a very, very scary image right here. This is a person who has a clot in transit. We always talk about whether or not we should be giving TPA in arrest blindly and just say, should we just give TPA and see what happens? You don't have to give it blindly if you see objective evidence like this. This clot in transit tells me that this person is arresting and they need to have TPA to survive. Now, one thing that we often talk about is a person who's intra-arrest or post-arrest having a big RV. And should that be the definition of whether or not they received thrombolytics? I used to think it was. However, there's been more recent literature that shows us that once you arrest and you're post-arrest and you get ROSC, a big RV doesn't necessarily mean that you have a PE. So you have to be careful of that interpretation. So I'm going to give you one study that goes a little bit outside the cardiac arrest literature, but I find it to be helpful. If you incorporate using ultrasound to find a clot in your lower extremity, and here's a big femoral clot right here, it may augment your clinical decision skills. So in this particular study, again, which will be in the handout at the end, they asked people the clinicians who they thought might have a PE, and these are non-arresting patients, so I'll just be clear, who they thought had a PE. They gave their pretest probability. They did the ultrasound. If the ultrasound had DVT, their likelihood ratio was 16 for having a PE. So you're much better at making a decision at the PE if you already see an existing clot. And if there was no clot present, the negative likelihood ratio is 0.7. This tells me that if I think the person has a PE, if there was some concern about it, I'm putting the probe on the lower extremity while people are doing compressions. I'm looking for a clot. If I find a clot, I'm more likely to give that patient thrombolytics. And if the clot's not there, then I don't feel inclined to blindly give this person thrombolytics unless the history strongly suggests that a PE was present. Another thing we can look for is pneumothorax. Now, I'll admit, this is not during cardiac arrest, these images right here. These are nice, clean, stable patients who there's no chest compressions happening. There's no rush to get the images. And that's why the images look so good. So when I put images like this up, people in the audience will say, well, that's never how a code goes. How are you able to get such a clean image showing a pneumothorax on the left? And I get that. But what I want to tell you is that you don't need these clean images to rule out a pneumothorax. In fact, if you see a B line, as you see here, these long streaking artifacts coming from the pleural line, you've effectively ruled out a pneumothorax. And all I care about is tension pneumothorax during a code. So these long streaking artifacts tells me there's no tension pneumothorax. We need to go on to the next step of our algorithm. Now, let's talk a little bit about prognosis of ultrasound during arrest, because whether you're in a big center or in a small center, arrests seem to suck up all the available resources that there are. And these are precious people that you need in your department to help see more sick patients and move the room, if you will. But look what happens here in arrest. Look how many people are in the room. Certainly there's some essential people like the code leader, the person doing chest compressions, the charge nurse, the person doing the airway, and the respiratory therapist. But there's so many other people that are there who want to help, who want to do something for the patient. Is ultrasound able to tell us whether or not those people should be there in case we need them, or whether or not the chances of survival are so low that those people should leave the room and go ahead and do other things? And the study I referenced before with the pericarditis was based off this study by Romolo Gaspari. This is one of the best studies in ultrasound in cardiac arrest, probably one of the largest that there is. Almost 800 patients included in this study with non-shockable rhythms. Again, we'll talk later about why you should not be using ultrasound for shockable rhythms, but for non-shockable rhythms, ultrasound can be extremely helpful. So they had almost 800 people. This was an emergency medicine study, all comers into the ED. And what they found is on initial ultrasound, if you saw cardiac activity, there was a 4% survival to hospital discharge. Now, we don't know if those people were neurologically intact. That wasn't the way the study was. But if there was cardiac activity on the initial ultrasound, survival was 4%. And I would say those are the people we should be putting more resources into during a cardiac arrest. So if you see cardiac activity on that initial ultrasound, by all means, dump all your resources into it. However, if you have cardiac standstill on your initial ultrasound, survival was 0.6%. Now, in some studies, it's shown 0%. In some studies, as high as 2.7%. But 0.6%, that means that it's not completely conclusive if you have standstill that you should stop resuscitation. However, let's say you had a patient who's from a nursing home, who's found down after 20 minutes, who has metastatic cancer, and you see end-tidal that's low, and you see a standstill on ultrasound. For me, that's enough of a clinical picture to say that we can stop the code. So this gives you another piece of data, albeit not completely conclusive to stop the code, but another piece of data that tells you that you can prognosticate your patients. And I find this tremendously helpful. So we talked about reversible causes. We talked about prognosis. I don't even have the time to tell you about all the procedures that we can use with ultrasound, but as emergency medicine physicians and critical care docs, I'm sure you understand that already. So let's move on and talk about some of the problems that could be associated with ultrasound. Now, I would be a liar if I came up here and told you ultrasound is just rainbows and unicorns and everything was great and nothing bad could happen, because that's simply not true. You have to use ultrasound responsibly when you're resuscitating your patients. The first thing that I'll say is that you should never, ever, 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 20 more evers, use ultrasound if this is the rhythm that you're seeing. This person doesn't need gel on their chest. They need electricity through their chest. Resuscitation with cardioversion for patients with shockable rhythms. Shockable rhythms should be shocked. Don't waste your time with ultrasound. The other thing that I saw over the years with ultrasound as it gained more popularity is that the rhythm checks tended to get very long because people did ultrasound and they started to consider the diagnoses that were happening. People got distracted from the only two life-saving skills that have ever been shown to be successful during cardiac arrest, and that's high-quality CPR and early defibrillation. So a lot of distractions that happen with ultrasound. And we know that the longer you're off the chest, the more your coronary perfusion time drops. And then it takes longer to build up those perfusions to the coronaries over time. Now, there's a study that was done over actually at the University of Maryland that looked at this. And this was an observational study, again, linked in the handout that I'll give you, that showed that when ultrasound was used as an observational study, they found that the rhythm check was 21 seconds. And I'm not throwing shade at University of Maryland. I worked there. I love Maryland. This has been repeated in other centers that shows that the rhythm checks are longer, this high, when you use ultrasound during resuscitation. Now, truth be told, when you look at the control groups, people that didn't have ultrasound, it was 13 seconds, arguably longer than a recommended 10-second time. But the point is that you can double the time with ultrasound if you don't know what you're doing. So I want to give you some tips for how to do ultrasound better. And these are things that have been taught to me or things that I've just used over the years. And I hope you find this helpful as well. Now, I love medical students, I love residents, but to me, the only person that should have their hands on the probe is the person with the most ultrasound experience. This has been shown in studies with interrater reliability, but we need somebody who's going to get on the chest, make an accurate assessment, and get off the chest as quick as possible. This is not the time to teach ultrasound. Teach ultrasound on the person who's in the hallway, waiting for a lunch tray. Those are the people you practice on, not patients who are critically ill. Time is critical, and you have to get on and off the chest as quick as possible. The other thing is, if you have the people power to do it, and I don't want to talk like an ivory tower academic doctor, but if you have the ability to delegate that person to just doing ultrasound, they should. That should be their only job if that's an option. If you're in a single coverage place, I get it. But if you can delegate someone just to do the ultrasound and that be their only job, you're going to be better off because they can focus on doing the scans, interpreting the scans, and leading the pathway when it comes to getting on and off the chest. Scanning during compressions is also important. So we're talking a lot about cardiac ultrasounds during arrest, but don't forget there are other things you could be doing when people are actively on the chest. You could be looking down at those groins, looking for that DVT. You could be doing a fast exam if you suspect that there's free fluid, looking for blood that's in the belly that could be leading to the arrest. The next thing you want to do is that when you know that the rhythm check is coming, you want to prepare your view. Meaning, when I know that the rhythm check is coming, I want to tell the person who's doing the ultrasound or myself, when we're like 10 seconds out for the rhythm check, get close to where you want to be, get the gel on the probe, and then just get right under there and get your view. There's no sense in waiting till the rhythm check is called, then putting your gel on and then looking for a window. You're wasting critical seconds there. The next thing I want to do, and this is good whether you do codes with ultrasound or not, is I tell the charge nurse, every time we do a rhythm check, I want you to count out loud backwards from 10. This lets everyone in the room know where we are during the rhythm check so you don't get lost. So I say 10, 9, 8, 7. And if I'm running the code and I see someone's doing ultrasound and we're to 3, I tell that person, please get off the chest, wipe the person down. We're getting back to CPR. But having that auditory feedback can be very helpful to tell you where you are in that rhythm check and keep you aligned with what the goals of that rhythm check are, getting information and then getting back on the chest. Next, I like to use the parasternal long axis view when I'm looking at my patients during the rhythm check. I know a lot of people like to use the subxiphoid, but our patients aren't always amenable to that view. So doing the parasternal long axis view right there allows me easy access to the heart and gives me very good quality images right there. The next thing is to just take clips. I find that ultrasound to be very hypnotic for people. They stare at the machine, they try to interpret things, they get lost in it. I just say take a clip and then do the interpretation during the next round of compressions, but don't spend too long trying to figure out what's happening. Just clip, 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 and then interpret on the next round. Have a towel handy. It's helpful to wipe down the patient when you're done with CPR. Protocols can be also important to keep you on track. There have been all sorts of protocols: the feel protocol, the fear protocol. We have the cause protocol. We have the cure protocol. We even have something called the shock protocol. And I'm not going to lie to you. If I could find something in an arrest that had the letter Y, there would be a Haney protocol as well. But the protocol I like the best is called the CASA protocol, cardiac arrest sonographic assessment, because this keeps things nice and simple. And what they did here was they said on our first rhythm check, all you should ask is whether or not there's tamponade, nothing else. Just ask the question, tamponade, yes or no. Get back on the chest. Next round, look for RV strain. After that, next round, you're going to look for cardiac motion. So every time you're doing a rhythm check, you're asking a specific question. So you don't try to do too much, and it keeps people focused. This study showed that there was a reduction in time by 3 seconds at a rhythm check. Now you're saying, what about the pneumothorax and the FAST exams? Certainly do those exams if it's clinically indicated in the patient in front of you. And the last thing I'll say is that if I have a situation where I do get cardiac motion on a patient and no one feels a pulse, then I'll put the pulse wave Doppler on the patient's groin. Here, this is color Doppler, not pulse wave. But even still, if I see a good, strong signal and they can't feel a pulse, then I wonder whether or not it's just their digitometers that aren't working. Or is the blood pressure so low that they need more augmentation? But this tells me right here that the person does, in fact, have a pulse. So just like they say in every beer commercial that you see, drink responsibly, use ultrasound responsibly when you're resuscitating your patients. So let's move on to the final point and let's talk about the future of ultrasound in cardiac arrest. Now, if you've ever heard the story, the best way to someone's heart is through their stomach, you think about food. That's what I certainly thought. But I didn't realize that actually it has to do with transesophageal echo. Transesophageal echo is the quickest way to look at someone's heart during an arrest. And I'm going to tell you right now, it is the best way. If you've ever seen one of these probes, then you know that there's the end of the probe has these crystals. These are the same crystals that are in the probe, but they're on this tiny little transducer that goes inside down the esophagus and sits right behind the heart. And then there are these external controls which can rotate and flex and bend the probe so that you can get almost every image that you can imagine. And because there's no bones, skin, subcutaneous tissue, or lungs in the way, and you're only a centimeter behind the heart, you can get some really good images, and you don't have to be a cardiologist or an anesthesiologist to get it. In fact, most people that do TE for the first time realize it's quite easy to get images. So right here, you'll see a transesophageal view. This is the omniplane, the rotation. We'll ignore that for right now because you don't even need to rotate during arrest. Here's the left ventricle. Here's the right ventricle. Here's the right atrium. Here's the left atrium. For some of you, you might be saying, this looks really familiar. This looks like an apical 4-chamber view. And you would be correct, because instead of putting the beams from the front of the chest, you're going from behind the heart. And that's why it's a mirror image. This is a clip from my friend Jimmy Fair. This is an intra-arrest TE. You see here a big RV. This person actually had a pulmonary embolism, got lytics, and survived to hospital discharge. This is intra-arrest. So you can do this ultrasound while chest compressions are happening. Look at this clot that's in transit. Again, received thrombolytics, survived to hospital discharge. This one by my friend Patrick Okersey. This is a aorta with a dissection in the ascending aorta. And they gave their fair shot. But looking at this, they were able to prognosticate, saying this person's not going to make it to the OR. And they terminated code likely earlier than they would have had they not had TEE. One of the things that I always used to laugh at when I was in medical school and residency was whenever I saw TV, they would shock asystole. And I was like, that is ridiculous. But I got to tell you, maybe they were onto something. Because if you look at this, is this asystole or is it fine V fib? This is an actual ultrasound for a patient that they thought was asystolic. They found fine VFib. They cardioverted, they defibrillated, and they got return of spontaneous circulation. The patient lived to survive. So this can be extremely helpful for things that you think you know, but actually looking at the physiology of the heart can be immensely helpful. It can also help you with the quality of your chest compressions. We think just pushing on the chest is, ubiquitous for everybody. But look at this. Right here, what we're having is the LV being pushed around, but not effectively compressed in the anterior posterior view. The person who is using the TE tells the people, move it a little to the left, move it a little down until you get something like AP compression where there's actually good compressions happening. So which compressions would you want if you were a patient? And then the last thing I'll tell you is that we talk about how long does this take? Well, in one study, 9 seconds during rhythm check to evaluate the heart, 9 seconds as compared to 16 in the control group that wasn't using ultrasound. And you can do TEE during chest compression so you can get lots of information while they're pushing on the chest. And this is why I think it's one of the most superior things that we can be doing. And I believe that every emergency department at some point in the future will be doing TEE. We crack chests open, we intubate patients, we do all sorts of procedures. There's no reason we can't put a large NG tube down with crystals at the end of it to help assess our patients. So what I want to do is I want to tell you that the most important thing that you have in your armamentarium is the organ that's between your ears, your brain. Don't think that ultrasound is going to be a replacement for all the skills and the knowledge that you have. However, what ultrasound does is it augments all the knowledge and skills that you've acquired and helps you find things that you never would have found. More and more data is coming out to show that ultrasound is vitally important for our patients in cardiac arrest. And I can personally tell you stories about patients who I walked into codes on the floors where we found reversible things and we saved people's lives. And this is stories that I have, my friends have, and I can honestly tell you, for an intervention that's so cheap and easy to do, why wouldn't you want to be doing this for your patients? So with that, I want to thank you all for your attention. What I want to do is I just want to tell you, if you have any questions, I'll certainly be there for the Q&A session at the end. But I'm available on all the socials. I do a lot of free open access medical education, YouTube, even TikTok. I'm on there. And my handle is Critical Care Now across the board. And finally, the link I'll give you, if you want to just take a screenshot or write this down really quickly, for that handout that you can get after the conference is resusx.com/ECS. And I've also included a couple videos just for you to watch free of charge, just so you can learn a little bit more about resuscitation and what we do at the conference. So with that, I thank you so much for your attention, and I look forward to meeting you all during the Q&A.
Thank you, Haney. That was fabulous. Definitely taking it to my next shift.